Welcome to Social Work Live, I think, with apologies for the delay that we've had due to technical difficulties, and we hope that those are all overcome and that we'll actually be able to have a conversation now. I want to thank all of you who have stayed around to see whether we would get on. So if you're listening, a special thank you. I'm Michael Friedman. I'm the host of Social Work Live. Every week we talk to somebody from the Columbia social work community about social work issues, and today I'm talking with Heidi Allen, who is an associate professor, our health policy expert here at the school, a person who has had a very interesting background in health policy, having worked on the Oregon health policy experiments and a variety of other things in her career, and is a recent winner of the Social Policy Research Award. So it's great to have you with us, Heidi, and I think what we're going to do is sort of wing it a little bit. If people start to send in questions, we'll probably try to take some of those questions earlier than we usually do because we're running so late. But today we want to talk, of course, about health policy, starting with Medicaid, which is something you did a wonderful TED Talk on.
Thank you.
And
I'm glad you watched it. You, my mom, my kids.
Well, I think my wife too.
Oh, good.
Yes, I think so.
Yay.
I think so. Maybe some other people as well. No, it was a great talk.
Thank you.
You did really well. But there, what you did was to take on some of the reasons that are given for attacking Medicaid. Medicaid is under attack by the Republican leadership particularly, and they think it's a bad way to go and give reasons for that, and you called that into question.
Yeah, so as many of you probably know, the Affordable Care Act was, intended to expand Medicaid to all uninsured low-income adults below 138% of federal poverty level. And then a Supreme Court decision, before it was implemented, ruled that the federal government couldn't tell states what to do. And the states had to make that decision on a state-by-state basis. And so, about half of states initially said, yes, we're going to do this. And then there's been this trickle effect over time where more and more states have opted to expand. But we still have, as of today, 17 states that do not have a Medicaid expansion. And in those states, low-income uninsured adults just stay uninsured. And what's really troubles me about this is the equity issue, in that if you made just a little bit more money, you would qualify for subsidized coverage through the marketplace. So you're too poor to qualify for government help on insurance. And that just seems like such an egregious
this is that working poor population that we're talking about.
Yeah. And if you would think of who needs government support for coverage, you would think, let's cover the poor, not let's cover the near poor and leave the poor on their own. And that's what these states that have not expanded Medicaid have done. And so they go back, opponents of Medicaid expansion go into the literature and they say, we can show you research that demonstrates that Medicaid is actually worse for you than being uninsured. And they will say, Medicaid is bad insurance. Nobody will take you if you have it because it pays providers so little. And they have all of these kind of arguments that they bring out. And the research that I worked on and been publishing on for the last decade was a natural experiment where we were able to compare the uninsured and those who had access to Medicaid using the gold standard randomized controlled trial that we would love to see in other aspects of research. And we were able to demonstrate with causality that some of these myths that politicians have been putting out there actually just aren't true.
So the fact of the matter is that people who get on Medicaid in general get better health care than people who don't have coverage.
Absolutely. The myth that Medicaid pays providers so little that nobody will have access and it'll be essentially coverage without care. Right. That is a myth. When we give people Medicaid, they have access and they use all sorts of care more. And
yet we have Republicans out there who are, and I guess I am being partisan. I can't not be partisan on this issue because it's the Republicans who are saying these things. But they are attacking Medicaid for a variety of reasons and with a variety of goals. So number one, as you mentioned, they want to stop the expansion of Medicaid under the Affordable Care Act. And number two, they're putting forward another proposal, which is to convert Medicaid from an entitlement to a block grant. And I don't know how many people understand what that means. It's very important. Maybe you could comment on that.
Well, I mean, I think that it just, currently the way the federal government pays for Medicaid is depending on what type of public insurance, Medicaid-like program. There's also the Children's Health Insurance Program, and there's different types of Medicaid. They give you a certain amount, if it's $1 is the cost, they pay a certain percentage of that. And a block grant would just say, we're just going to give you this set amount to cover your population. And I think that what people are concerned about is that it will not rise with medical inflation. They'll set it to some other kind of inflation, which means year one it might work. Year two, as healthcare costs go up, states would find that they don't have enough money to cover people, and they will start doing things to get people to disenroll, like work requirements and things like that. And also, the Medicaid program ebbs and flows with the economy, which is unfortunate when paying for it is tied to state taxes and even federal taxes, because the higher the unemployment rate, the more people would be eligible for Medicaid, the more the program would grow right when the tax base to support it shrinks. And so that, I think, is a problem with block grants, is that, that might be more pronounced if the federal government ends up kicking in less money to the states. Then the states would be more and more susceptible to those changes in their budget.
And the key point is that just to go back a step, make sure people understand that Medicaid is a joint federal-state program.
Yes.
And the federal government is paying a portion of the costs of the Medicaid program that's run by the state. And its commitment is to cover a certain portion of the costs, no matter how big the costs become in any given year.
Which is where the block grant might
so it's very different from a budget
Yes.
in which the federal government said to the state of New York, for example, we will give you $20 billion this year, and well, if there's an emergency and things happen we didn't anticipate and it costs more, tough.
It's right. It's like trying to have a family budget, only we're not going to tell you how many kids we're going to give you next year.
Right.
You might have 100 kids or you might have 3 kids, and this is your budget. Well, if you only have 3 kids, the budget might look fantastic. If you suddenly have 100 kids, everybody might be struggling.
So most of us who are on the side of making sure that people have health coverage are opposed to this block grant approach, because it could end up with covering a lot fewer people, or maybe just towards the end of any given year, but it could be a real problem.
So states face difficult budget decisions. When you think about what healthcare competes with, it competes with, education. It competes with roads. It competes with child protective services. All sorts of different programs that we rely on, and Medicaid is it takes a lot of states' budgets, and they understandably get worried when the federal government suddenly looks like they're going to pay less, which is a little confusing to me. One of the arguments that Republicans often make against expanding Medicaid is that the federal government in the Affordable Care Act will pay 90% of the costs of every new enrollee. It's actually more than that, but at the very lowest, they say it'll be 90% of costs. And states, Republican leaders in states have said, well, what if down the road Congress changes their mind and asks us to pay more? We would be in a very tough position because we don't have that money. So that's what's interesting to me about the same political party saying we are interested in block grants, because the same risk of federal priorities shifting and a mismatch between what the federal government pays and what states can pay, it's the same kind of problem. And I think it's a problem that's worthy for states to consider. They need to be able to afford whatever program they have. Like, that makes sense. What I would like to see us do, whether we're talking about Medicare-for-All or Medicaid-for-All, or however we think about paying for it, is can we get to a place where we're rationing maybe services and not people? Because currently what we always do is this implicit form of rationing where if there's a budget issue, we find a way to cut people. You know, whether we just make it so expensive they can't afford it, whether we put in work requirements and a bunch of people, you know, or drug testing, or all sorts of, you know, lockout periods for non-payment of premiums. There's all sorts of policy tools people use, but they're all just ways of decreasing the number of people who are enrolled to make the program more affordable.
There are also other ways in which controls have been set on Medicaid over the years. Certification of need processes, for example.
For hospitals.
For hospitals and for other programs as well. I don't know the whole country, but in New York State, any new program that's going to use Medicaid has to go through this kind of process. And also in New York, I'm not sure where we are now, but we used to do rate setting so that instead of squeezing down, as you're saying, the number of people served, we squeezed down the rates that hospitals and nursing homes were paid. Something which I think is
so that's another way.
Still going on.
Another way is we could look at the 1/3 of care that doesn't provide any health benefit, and say.
Well, say something about that. That's interesting.
I mean, so there's good evidence that 30% of the health care that's provided doesn't result in any tangible health benefit. Some of it is the giving it to the wrong people.
So when I have a cold and I insist on going to the doctor, when I really should just stay home for 7 days and I'd be fine. But.
I mean, that's where we like to target. We always like to target trying to keep people out. I don't know if people are the best judge of whether they need health care or not. You know, I study health care and I still don't know when I should go to the emergency room and when I don't sometimes, or when my kids should go, or I mean, because I'm not a physician. And even if you were a physician, you don't have access to labs. You don't need, you know, when faced with just symptoms, it's very unclear what the treatment needs to be and whether it's urgent or not, which is why I think that looking at emergency department visits and saying, oh, should people have gone or not, is kind of, it's not the way to think about it, because if your chest hurts, yes, it could be indigestion. It could also be a heart attack. Right. You're not going to know until somebody does the test.
Well, let me just push us ahead.
Okay.
All right? Because I think we can talk about how to control costs for a very long time. It's a fascinating issue to us anyway. But you did mention Medicare-for-All before, and one of the ways in which at least a portion of the Democratic Party has been responding to the Republican positions on health care is with a pushing for something they call Medicare-for-All. There are a number of different versions of that. You want to comment on that?
Well, so I mean, the last thing you said is, I think, the most important when commenting, which is that there are a number of different versions. I think I've counted at least 10, and they're really, really different. So when you say Medicare for All, I don't know that we're talking from a program that would replace employer-sponsored insurance, which means it would truly be Medicare for All, which would be...
Well, it would be government-based single payer for all.
Yes, it would be, but it would be a complete transformation of our healthcare system.
Right.
Complete transformation. Or some people say Medicare for All, and what they mean is gap coverage for people who are falling through the existing cracks, where they can essentially apply and be guaranteed, you know, a place that they can go to get affordable health care, which might cover 20 million people. So those are really different, and they're different in whether or not, you know, one thing that not everybody knows is that Medicare, even though it's the program for elderly adults and people with disabilities, it doesn't cover long-term care, which is the most expensive form of care that we have in our healthcare system. It's residential care. And that is paid for by the Medicaid program for people who spin down to Medicaid eligibility. And these programs differ of whether or not they cover long-term care or not. So I think that if I were...
And what the fate of Medicaid would be as well, I assume.
Right.
Not all of them say, let's get rid of
employer-sponsored
Medicaid.
insurance, yeah. But I think if I were speaking to a social work audience, or audience that cares about making sure that whatever we do that it makes care better for the poor and underserved and doesn't make it worse. I think that there are some things that we need to pay close attention to, and one of those things is universality. And I don't mean is it completely replacing or not, I mean is everybody covered? And some of these are more explicit than others. Is everybody covered? And I think ideally we want the kind of coverage that people have for long periods of time. Only if you give people and you say, I'm responsible now for paying for your care for a decade, I'm going to think about your needs a lot differently than if I'm responsible for your care the next year.
Absolutely right.
And we have all this body of research on the social determinants of health, and yet all of our interventions in healthcare policy related to the social determinants of health are very tepid, because we only can look for gains that we're going to see in the next year. If I'm your insurer, I have no incentive to think about next year.
Let me just give you an example of that. I was on the board of a Medicaid managed care organization some years ago, and I discovered that there was a vacuum cleaner that was available that, if it gets used, a good study on this, would reduce asthma very considerably over time. So I set up a meeting between somebody who knew about this idea with the head of the managed care organization, who said, this is a great idea, but we're not going to do it. Why are we not going to do it? Because we have so much churning, as it's called, that we don't serve the same people from one year to the next. So we'll do the investment, but somebody else will get the benefit of it. We're not going to do it.
And that's true of Medicaid, and that's true of marketplace coverage, and that's true of employer-sponsored insurance. Nobody right now but Medicare has an incentive to really think about long-term investments. And even Medicare doesn't really have that much of incentive, because they're serving a population that is at the end of their life, not at the beginning. And so when I think of, trying to make the healthcare more complex, no. I don't think we should do anything that makes the healthcare system more complex. Trying to think of how to move the healthcare system towards a place where we can do these long-term investments, yes. That would be amazing.
So we have a question.
Okay.
And I really want to say something else, but we have a question. Could you give an example of people getting services in this 1/3 that you mentioned that are not needed or useful?
I could give you so many examples, but I think that where we find the most examples are in diagnostic imaging. So a lot of people get diagnostic imaging where it's not clear what they would do with what they found. It exposes people to unnecessary radiation, and sometimes it leads to what we call overtreatment. And overtreatment is another example of when we're spending money that isn't getting a health gain. And where we rely on policy to deal with that is usually trying to create standards of care based on, committees that are formed that say, if you have this test, this is the kind of care that you need. This is the kind of diagnostic imaging that you should get. When I was pregnant, I had 4D ultrasounds every single visit. And it was because, they said, oh, your son his kidneys are swollen, and so we need to keep an eye on this. And at the end, when he was born and I took him in and they did the last kidney scan, they're like, oh, it's back to normal. And I asked, well, why is that? What happened? And they're like, oh, kids, baby boys don't always like to pee in utero enough. Like, that was the reason that I got for having 4D ultrasound scans, like every single, first it was monthly and then it became weekly. I think that there's a lot of care that we provide that doesn't show any benefit.
And it does seem pretty clear that some of that is because there's money made doing it that way.
Of course. Like, it's not, it's
I think some of it is
self-evident.
anxiety on the part of the doctors that if they don't catch something that they might have caught if they had done these things.
But isn't it nice that your anxiety is aligned with the incentive that you have to make more money?
Fundamental Marxism. Where you sit is where you stand. Right?
I mean, I think that, medical malpractice, people bring up that as, a reason, and that's kind of a whole other policy topic. But yes, like, why not? Why not throw everything at it? Because there's no harm in it, or we don't necessarily see the harms in it right away. And the benefit to you as a provider, or maybe even you as a patient of feeling like, you've had all of these things looked at, might seem to be high. But when you look at long-term studies on many of these things, the people who got all of the care are not any better off than the people who didn't. And that's the kind of evidence that we need to drive.
And one of the arguments that's made is that if patients don't have skin in the game, that is to say, if it doesn't cost us much of anything, or anything meaningful, then why not?
That is an argument, but have you ever tried to figure out what your skin in the game is? Like, so you have a 20% co-insurance payment for all laboratory tests. Great. Well, now the doctor has 10 lab tests they want to run. You have no idea what your 20% is. You have no clue. And the provider's not going to tell you.
Well, if you're on Medicare like me with Medigap, the 20% is covered by another insurance plan.
Right. So, I mean,
So
I think
have
that
got
is,
right?
yeah. So the skin in the game argument really affects people for whom that cost makes a difference of whether they get something or not.
Right.
And I don't know that it's ever a good policy issue that the cost of something that you don't know if you need or not should be the deciding factor. I mean, it seems like the first factor should be, do you need it or not?
Well, this does suggest the rationale behind managed care and utilization review. That is to say, you can't expect the patient to make an educated judgment about what they need. It's
Right.
not like buying a car. This is a lot more important, and there's a lot more to know that's technical, and you can't expect the provider to be making a totally honest judgment about what people need because they get benefit from it. And so managed care comes into existence as having a third party in between the two. They probably benefit from doing less rather than more, but at least they have the information to make a judgment.
Right. But they
and
also
different
have
incentives.
but their incentives are actually, their incentives are to spend less.
Yes.
Right. I mean, and I think that's an incentive that people have a problem with.
Particularly since they've moved from administrative
Yes.
systems to capitated systems.
Yeah.
But we're getting too technical here, I think.
Yeah, but I think
for
that,
the
you know,
audience.
for social work audience, I think that what people want to think about is each of these decisions has multiple ramifications for low-income people. And we want to think about how do we, you know, what we want is a system that is universal, and we want a system that's affordable. And that doesn't mean just the very poor, but also people who are really just struggling to get by, which is most of America.
And there are a
really
number of
think
different
about that.
ways to get to that, which we should come back and talk to. I mean, the
There's
government-based
a lot
single
of
payer
different
is not
ways
the only way to do
There's
it.
a lot of different ways to do it, but the devil is really in the details. And
Absolutely.
I think that what we as advocates need to be is very good consumers of, you know, these are the things that we care about. How does your plan address these things? You know, there are trade-offs in trying to protect the finances of the poor and protect the finances of the sick. You know, to protect the finances of the poor, we usually have high deductibles and low premiums.
Right.
You know, so that if you use care, you spend more, but if you're a healthy person, you know, the premiums are really low and you can actually afford to have coverage. For the sick who might touch, you know, 5 different clinicians in any given week, we want that cost sharing to be low and premiums to be high. And so it's just a matter of understanding the system enough to see where these levers are and who are the winners and losers of any policy proposal.
Hopefully we can come back to some of this. We have another question. I recently read an article about Medicaid expansion, which has boosted the financial state of some hospitals. However, the cost for the insured patients hasn't decreased. I've been trying to understand why the millions saved by a hospital would go towards more high-profit areas of the hospital, such as more high-tech emergency rooms, rather than lowering the cost for consumers.
Well, because even nonprofit hospitals are in the business of staying in business. And part of staying in business means being competitive, and being competitive for what they call market share, which means well-insured patients with conditions that cost a lot of money, right? So why would you have a psychiatric hospital in your unit in your hospital which has a lot of indigent patients or court-ordered patients or Medicaid patients or Medicare patients when you can have a new special cardiac procedure that has the people come in tend to have private insurance and they have these very specialty surgeries done and the equipment is high tech. It's like anything, you're building to recruit the patients you want to serve, and all the incentives are such that hospitals want to serve the patients that pay the most. That is part of their viability and staying in the market, so some of that is responsible. And some of it is, you know, that these hospital systems that are nonprofit actually have very big reserves sometimes that, you know, should be going back to the consumer or not. So maybe it's a lack of oversight. The hospital associations are very good lobbyists, and I think they work very hard to make sure to protect the financial bottom line of their hospitals. And, you know, perhaps the government needs to have more say over what it means to be a nonprofit hospital.
Hospitals also have very high pay at the top levels. And
of course.
lower pay at the
Low levels.
low levels.
Yes.
Um,
Yeah.
So that part of what's going on is not just the building of the image of the hospital empire.
Right.
And my sense of things is that in the not-for-profit hospital world, there's huge amount of empire building that's going on, some of which for economic reasons, some of which for the same reasons that everybody builds
I have
empires.
a colleague who once said that you can't run into a crane in the city without it being attached to a hospital. And that seems to be true. There's always tremendous growth, it feels like, in the hospitals. And we have to think about, is that the kind of growth that we want to encourage? Building a hospital means you have more sick people. Do we want more sick people? No, we want healthier people. And at some point, we have to redirect resources towards keeping people
So
healthy.
that brings us to a whole different perspective on this, which is that the discussions in the United States today are all about health care. And there are virtually no discussions in the political arena. In our arena there are, but in the political arena there's almost no discussion about public health, population health. There's no discussion about health. There's discussion about health care. So we want everybody to have health care, but we're not putting much of anything into making sure that as many people as possible are healthy. So two different things.
Part of that is that we don't have cradle to grave coverage, so it's not clear who wins if we keep people healthy over the long term. And we have healthcare, which is not, as you mentioned, there are some people who make a ton of money in healthcare, but even at its very basic, it's at least a middle class jobs program.
Yes.
So many people have their livelihood attached to the healthcare system, and that livelihood is sufficient to support a family. And so that is another reason why we have this conversation.
And it's very important, I think, to keep in mind that since the recession, the healthcare industry has either been number one or number two as the jobs creator. So people are out there saying, oh, look at all the new jobs that we had, whether it's Obama or Trump. There have been lots of new jobs. Look at where the new jobs are. And they're largely in healthcare.
If we wanted to really take health on, we might have to regulate things that we don't currently regulate. Like the food industry. I mean, we regulate the food industry, but we might have to further regulate the food industry. We might have to further regulate the gun industry. Like, there's all sorts of other policy choices that we might have to make if population health, we might have to address poverty in a meaningful way. And so, as you can see, there are entirely different conversations that require varying levels of political will to address. In some ways, it's just so much easier to talk about healthcare.
Well, I think, you're mentioning having to take on poverty. There's a push to recognize, at least among those of us who are in this field, to recognize the social determinants of health and to do something about it. And then we're talking about things like poverty and discrimination and
if we did
access to guns.
If we
and
did
so
have a
forth.
health insurance plan that was responsible for people for decades of their life, then they very well could construct budgets where they think about how could we get 10 years of savings from something that we do now.
And then
Instead of like 1 year of saving, which means you only really intervene on the highly vulnerable or the already very sick.
Right.
Whereas the rest of America, if you look at the onset of chronic disease, it looks like a step, a stair step. As you go from one age category to another, your risk of having a chronic disease goes up. That's a predictable increase. We should be able to change that.
A good question. What's
What is
the
difference between Medicaid-for-All and Medicare-for-All? Medicaid is health insurance for the poor, and Medicare is health insurance for the elderly and disabled. So they've been designed around very specific populations. Medicaid is a state and federal partnership where states actually have a lot of the policy-making purview,
Authority.
and Medicare is a federal program where states do not have a lot of say. Those are some fundamental differences.
So we have another way of saying this is we have 50 different Medicaid programs in the United States, one for each
They have
state.
a lot in common, but yes, we do.
And
in a
Medicare
Medicaid program, a state has the opportunity to be highly innovative, and a state also has the opportunity to be highly regressive. And that's not the case in Medicare.
Michael Sparer, as you probably know, who's the health policy person at the Columbia
chair.
School of Public Health, has made a case for doing Medicaid for all rather than Medicare for all. And part of the
makes
argument
sense
is
on a lot of reasons, because a lot of the remaining uninsured are low-income people. And Medicaid is a program that was built to serve the poor, which means that it'll pay for you to have transportation from your house to a doctor's visit, whereas Medicare does not pay for that.
I think he also liked the fact that Medicaid is more like the Canadian system in some ways, in that in the Canadian system there are different insurance plans in each of their provinces, so that they get more diversity in the in the specifics of the plans. And I think he thought that that might be of benefit in the United States as well.
I mean, Medicaid is much smaller, since it's, it's not much smaller at the aggregate,
Right.
but on a state-by-state basis. So that means you have a lot more opportunity to innovate and to build local relationships than you would in a federal program. But again, so the good thing about Medicaid is I do think when you're talking about which program serves the poor better, I mean, Medicaid serves the Medicare poor. Let's be clear.
That's right.
That's dual eligibility.
Right.
So Medicare in itself really is not designed to serve the poor. If you are poor, they give you Medicare and Medicaid. And so just not thinking about Medicaid and thinking about Medicare could really disadvantage people who are very low income. But Medicare has a level of acceptability to it that Medicaid doesn't have, partly because they pay providers more. And if Medicaid were to pay providers at Medicare rates, Medicaid would have more acceptability. I mean, that seems to me to be completely self-evident.
So we're getting to the point where we need to wrap up.
Okay.
As I always say about Medicare-for-All, there are no Medicare-for-All proposals which are actually Medicare. They are something they call Medicare.
They would have to be different. They're serving a different population.
Right.
Yeah, they'd have to be different.
So everybody's advocating for free Medicare, and there is no such thing as free Medicare.
Let's advocate for universality. Let's advocate for affordability, which means the government having the ability to set prices and say, we're going to pay for things that work and not pay for things that don't. Those are the things I think we should really be keeping our eye on.
So
and the
on
rest
that
of it
note, you get
okay.
the last word.
Well, that was my last word.
That was your
Okay,
last word for
yes.
today.
All right. Thank you so much.
And we're going to wrap up now. I want to thank you, Heidi, for
Thank
joining
you.
us today. I think
great
it's been
to be
a
here.
terrific conversation. And I want to thank those of you who stayed with us through our sorrows of technical difficulties and have stayed with us for beyond the 12:30 time that we are used to having. We hope you'll come back next week, and we hope that we'll begin at 12 noon next week. So tune in then.
Thank you.
Thank you. Thank you, Heidi.
Thank you.